Welcome everybody, and a big namaste to all of you. And thank Professor Malla, Dr. Azad, Professor Ava, and all the rest of the speakers and panelists for joining in this very important webinar in AIOS virtual conference. You see, this webinar is primarily meant to design some guidelines for the benefit of SAARC countries, because DME is a very frequently encountered problem everywhere, and in every country there are different issues. So SAARC has some peculiar issues, and that is the reason I think Dr. Azad stressed that we should discuss up in this webinar about how we should be approaching DME from practical point of view. And we have some very good speakers. Dr. Rajiv Raman has already published guidelines, everywhere. He has so many articles in IGO, and we also recently published. But if anything is unique for SAARC, we will stress upon those particular points. So I'll just run through this. So is this video running or noise? Rajesh?
Noise is not coming, sir.
Noise is
No
not
sound,
coming.
no sound.
No sound is coming.
Yeah.
Okay, I'll just...
I think you have to play, sir. It is not in the slideshow till now. It wasn't in the slideshow.
Okay.
Is there now? We can.
In Grover, technical team, please help him.
Yeah, it's okay.
Please.
Is it running now?
Yes, yes.
Yes, sir, perfect.
So this webinar has been named as Pedagogy for Management of DME, meaning how we practice teaching in DME. Very thankful to Professor Malla, Professor Hawa Hussain, and Professor Azad. This in brief will be the topics which will be taken up, not a very big program, only 4 or 5 topics just to help us in preparing guidelines. So chairpersons and co-chairpersons and panelists, most of us are here, and speakers, I see everybody virtually present here. So with this few remarks, I'll hand over to Ili, who is the main convener for this session. Ili, over to you. First talk is on epidemiology, and Dr. Ili will be stressing on the overall magnitude of problem of diabetic macular edema. After this, we'll proceed for diagnostic tools, then assessment of parameters and medical management, and then drug therapy and surgical aspects. So, Ili, you can share your screen.
Thank you, everyone, especially Professor Azad, Dr. Lalit, sir, everyone for inviting me, and Abandon Master. So I'm going to, the overview and the best diagnostic tool management everything will be, speaking by other speakers. So what I'll do is I'll just go through epidemiology in the SAARC region as well as overview of so financial disclosure nil. I'm from Tilyanga Institute of Ophthalmology, Kathmandu, Nepal. So diabetes mellitus, is a leading cause of morbidity worldwide. Prevalence is increasing, especially in low and middle income countries, especially in the SAARC countries. It's not going. Okay. The prevalence of diabetes is estimated to be 4.4 into 2030, and as the urban population is increasing, and especially more than 65 years of age is increasing, so that is definitely the change. List of countries with highest number of estimated cases. India is being the largest one, China, US, Indonesia, Pakistan, Brazil, Bangladesh, Japan, Philippines, and it's in a row. So the important vascular complication of diabetes, of course, diabetic retinopathy is the fifth leading cause of blindness worldwide, although it's the preventable condition. It affects the vision of 2.6 million people in the world and responsible for nearly 0.84 millions of 32.4 million people. Diabetic macular edema, which is our main topic now, is a leading vision-threatening form of diabetic retinopathy affecting around 21 million people worldwide. It's the most common cause of visual loss in type 2 diabetes and may affect patients with diabetes. My slide's not moving. My slides are stuck.
Can you go back and then come again?
If you go to the lower side of the slide on the left side, there's an arrow. Yeah, press this. Yeah, this, yeah.
Yes. Diabetic macular edema, it is the thickening caused by accumulation of intraretinal fluid, mainly in the inner and outer plexum layer, result of hyperpermeability of retinal vasculature, and it can happen at any level of diabetic retinopathy. According to ETDRS, clinical significant macular edema, CSME, which we call as, it's a retinal thickening at or around 500 micron or 1/3 disc diameter of center of the macula. Hard exudates within 500 micron of the center, and retinal thickening greater than 1 disc diameter, in which within the 1 disc diameter area from the center of the macula. According to Wilkinson Epidemiology study of diabetic retinopathy, it's in a type 1 over 10 years period, it's 20.1%, type 2 25.4% in group taking insulin, and nearly 14 in group not taking insulin. And prevalence of macular edema increases with 3% within 5 years of diagnosis to 28% after 20 years of duration of type 2. And according to DCCT, it's 27% of type 1 diabetes patients develop macular edema within 9 years of diabetic onset. So this is the overall prevalence of diabetes, prevalence of diabetic retinopathy, and prevalence of diabetic macular edema, taken from different references, which is going to be presented at the end. So if we start from these, there are 8 SAARC countries. Afghanistan,
this is
12.1, nearly this is Afghanistan, 12.13%, 1.4% of diabetic retinopathy, and prevalence of DME is not known. Bangladesh, it's the 8% diabetes, 33% of diabetic retinopathy, and there is a large population-based study, and where I think Dr. Deepak Nag, which is one of the panelists, is co-author of this article. There's 34.1% in Chittagong Eye Infirmary, 5.4% in Ferry Diabetic Health Center, 30.3% in National Eye Institute. Bhutan, 8.2% of diabetes, prevalence of diabetes is not known, and prevalence of DME is also not known. India, being the largest of all, prevalence of diabetes is nearly 12%, and the diabetic retinopathy ranges from 17.6 to 28.2, and prevalence of DME is 29%. Maldives is 9.2%. However, the prevalence of diabetic retinopathy and DME is not known. Nepal, our country, it's 8.5%. It's again from the population-based study. 23.8% prevalence of diabetic retinopathy, 4.2% of DME. In Pakistan, 17.1% diabetes, 28.78 DR, And in NPDR, it is about 15.50, nearly 50%, and DME in PDR is nearly 5%. Sri Lanka, 8% diabetes, 27.4 diabetic retinopathy, and 5.3% of macular edema. So these are all from the population-based. This large population has been taken and it was cross-section study. So briefly in review briefly about the diabetic. There are different classifications. It's mainly our aim is to help for the management of diabetic retinopathy. It could be central involved, central not involved, classified according to focal when it is caused by microaneurysm, which tend to leak fluid, and diffuse when there is a dilated capillaries in the retina causing diffuse edema of the fovea. There are foveal FFA-based angiogram. There's a OCT classic-based angiogram. OCT-based classification of diabetic macular edema. There are different classifications, but our main aim is to treat and manage diabetic macular edema within the SAARC region. Risk factors, according to Wilkinson epidemiology study, it's high level of glycosylated hemoglobin, severity of retinopathy in both younger and old onset female, and increased diastolic blood pressure in older age group. Systemic factors, duration of diabetes, age above 40, systolic blood pressure, high HbA1c, anemia, increased serum cholesterol, and obesity. And the main ocular factor associated with DME is severity of diabetic retinopathy. How to reduce the burden? Early detection, accurate diagnosis, timely treatment, and comprehensive program for the detection and management of diabetes is needed to decrease the incidence of complications. So these are my references for all those, accumulated SAARC incidence and prevalence of diabetic macular edema. And this is all. Thank you. Now, with this, I would like to request Dr. Malika Goel for diagnostic tools in DME.
Thank you very much. Thank you, Doctor. I'd like to thank Professor Azad, Dr. Lalit Verma, and the AIOS for this opportunity. So I'll be speaking on the diagnostic tools, especially with a focus on screening methodologies. So as the previous speaker mentioned, the reason to screen is because it happens, the complications can happen without any symptoms, and these are preventable with early treatment. And hence screening protocols can identify diabetic retinopathy at a treatable stage. Now, these are the diagnostic tools that we have for DME and retinopathy. However, most of these are not sustainable with the huge numbers, the millions of patients with diabetes, and especially with limited resources in developing countries. So the future lies with artificial intelligence systems which use machine learning and deep learning. These are cloud-based and are able to take retinal images, automatically exclude suboptimal images, analyze them, compare with patients' previous images, and generate a number which gives the likelihood of referable diabetic retinopathy being present. And several systems are already available, but not FDA approved yet. The advantages are that these can grade thousands of images a day without getting tired. They can provide results within minutes and seconds of taking the photographs. And scaling up means simply acquiring more hardware. But while those are not yet available, what we do have is Fundus Imaging. The conventional imaging systems capture the central 30 to 50 degrees. Wide field imaging is more than 50 degrees, and ultra wide field imaging is angle more than 100 degrees. These are the systems that are available with ultra wide field imaging. There was a landmark study by Dr. Ailo et al. In 2018, it was published with 737 eyes, where they compared the standard fundus camera with the ultra wide field imaging. And they found that approximately 34% of diabetic lesions are outside the standard 7 fields of the regular fundus camera. And in fact, neovascularization is seen outside the regular fields in 45% of the cases. So basically, we are missing blinding retinopathy if we go just by the standard photography. 26.9% had greater severity of diabetic retinopathy on the ultra wide field images. But in both systems, maximizing the image quality is of paramount importance for accurate results. The other advantages of ultra wide field are that no dilation is required, no contact lens, and acquisition time is less than half of standard photography. Evaluation time required is less by 30%. Much less images are ungradable or undecipherable. And when you see the ultra wide field images, the severity scoring matches the clinical examination in 70% and is different from the clinical exam by within only a level in up to 93% of the patients. So this is a definite improvement over the standard photography for detection, grading, and treating diabetes. Which shows us the leakage, the enlargement of FAZ, capillary non-perfusion, and neovascularization. So this is in DME, focal leaks, which allow us to do focal laser, diffuse leaks, which are better treated with injections. And if you see, the leakages can be identified away from the exudates in the inferotemporal area as well. So angiography can give us an idea about the leaking. Cystoid macular edema, which gives an idea about how to treat. Laser doesn't usually work. It could be a combination of the two patterns, the diffuse component requiring laser and the cystoid component responding better to injections. And then severe macular ischemia, which gives a guarded visual prognosis. A lot of non-perfusion. And importantly, unsuspected neovascularization when we are looking for DME only. And even sometimes we can pick up neovascularization iris, which was not suspected from a featureless retina. The foveal vascular zone, very important in diabetic macular edema, which gets enlarged and irregular in diabetics. And ultra-wide field angiography can pick up new vessels outside the standard zones. And we know that that is more often associated with diabetic maculopathy. The next instrument, which is the most important, is the OCT, which gives us a histological cross-section of the central retina. These are the 10 layers, and it assesses the central 6 mm, of which the central 1 mm is the fovea. And this gives us retinal thickness maps. As you see, the blue line showing that the retina is thinner than normal in the on the right side, so that even if the patient's edema is improved, vision may not improve much. It shows us the type of edema, cystoid macular edema, or subfoveal fluid, which has a better prognosis, or an exudate, which can be followed up on treatment, exudate with membrane, which has a poorer prognosis. And it helps to monitor the response to treatment so that we can change the management. This is showing release of VMT after giving an injection so that surgery can be avoided. Spontaneous VMT after laser. So this is the way OCT at every visit helps in treating a patient. This is where an ERM is not allowing the macular edema to resolve, and post-vitrectomy it resolves. Similarly, another patient. Very importantly, it gives us the prognosis. Damage or disruption of the external retinal layers gives a poor prognosis right in the beginning. Or the presence of drill. This is the absence of demarcation between the inner layers. As shown here, more than 50% of the area in the central 1000 microns. If it is affected, that is considered significant for poor prognosis. And it correlates with capillary non-perfusion and FAZ side. The OCT also allows us to see a lot of other biomarkers for prognosis. It helps us to track a patient's increasing vitreomacular traction and also the macular contour in a TRD with lamellar macular hole, traction, etc. It helps to assess whether there is only macular edema or whether the retinal detachment has also involved the macula. This we cannot see by any other means except OCT. And even in the presence of significant vitreous opacity, we can still do an OCT and diagnose macular edema. It also detects thinning or ischemia, and most importantly, perifoveal telangiectasia, which does not need treatment and has a guarded prognosis. And this coexists with diabetics very often. Or an outer lamellar macular hole, where you will not continue treating because you know the cause for the problem. Now we come to OCT angiography, which is also like fluorescent angiography, but has several advantages in being non-invasive and being automated. So it gives us a lot of analytic data. The disadvantage is, the advantages include, apart from non-invasive, is it can detect capillary non-perfusion areas better than fluorescent because it is not overshadowed by the leakage of fluorescent, and gives several three-dimensional images. And there are OCTA biomarkers like retinal vascular density, FAZ size, intercapillary spacing, fractal dimensions. And this is to show that it can be superior to FFA in capturing the microaneurysms, as you see with the arrow on the right. The OCTA has picked up microaneurysms which are not seen on the FFA on the left. The FAZ size and the capillary dropout areas are very clearly seen in the superficial and deep capillary plexus. And the non-perfusion, as you see on the right side, is also correlating with the disruption of the external limiting layer on the B-scan OCT, which gives the poor prognosis. So
Ma'am, can I request you to please sum up?
Okay. This shows the new vessels and the non-perfusion. How much time do I have now?
Ma'am, we don't have time. If there are any questions, I'll give you 1 minute to answer those questions. And then if there are no questions, you can continue for 1 minute for your presentation.
So 1 minute more now, right?
Yeah.
Okay.
So you don't have any questions then.
Okay. So autofluorescence is another, the disadvantages of OCTA is that the field of view is very small and it cannot assess the leakage or the delayed transit time. And it takes a lot of time to take the images. Alignment is a problem. Patient cooperation is a problem. Adaptive optics and multimodal approaches are also useful, especially microperimetry, which gives the functional performance of the macula and can be used with advantage. These are newer tools. So in summary, the delivery of these screening methods is moving at a fast pace. It is only the artificial intelligence-based systems that are the future. But currently for diabetic macular edema, it is the OCT, which is the morphologic gold standard, and microperimetry for functional evaluation. For diabetic retinopathy, it is the non-mydriatic ultra-wide field, fundus imaging, and fluorescent angiography. Thank you.
Right on time. So I think, this was most important talk for epidemiology because you see in developing countries, all these things, Octa and adaptive optics, they're of more of theoretical importance because they're not widely prevalent. So I personally think OCT, hello?
Yes,
OCT
sir.
sorry. So OCT is the main tool. You see, angiography being invasive, its role is decreasing. Because OCT, apart from giving diagnosis, differentiates medical and surgical cases, prognosis, tractional, non-tractional, then follow up. I think this is one tool which has revolutionized the management of a whole lot of retinal conditions, including DME. I think for the sake of time, I think we'll move on. We lead to the next talk by Dr. Rajiv, which will be systemic. Hello, systemic parameter and medical management. Yeah.
Thanks, sir.
Yes,
Thank you, sir. Can you see my slides?
Yes, please carry on.
I thank Professor Azad, Dr. Lalit Verma, and Dr. Eli and the team for inviting me to give this talk on the assessment of systemic parameters and the medical management in diabetic retinopathy. 1 second. I'll just reduce this. Yeah. So diabetic retinopathy is a microvascular complications, and that suggests that it also involves other part of the body. And definitely these other complications may have some bearing as far as DME management is concerned. And there are a whole lot of systemic conditions which can have effect on diabetic macular edema and the way we treat it. Coming to the first one, that is glycemic control and diabetic macular edema, there are evidences which are very differing between whether there is a role of glycemic control in achieving a good response of an anti-VEGF The studies which were done a couple of years back, the protocol I, RISE, RIDE, they didn't find any association of HbA1c and the treatment response. However, the newer studies, the protocol T, VISTA, VIVID, they all found that there is a response as far as the OCT thickness reduction is concerned. It is dependent on HbA1c levels. That means for a better control of diabetes, you can get a better response of your anti-VEGF. Which anti-diabetic drug is best for DME? All are good. There is no extra benefit of one agent over other today. However, one must realize that whenever you initiate the treatment of type 1 diabetes with insulin, or whenever you switch from OHA, oral hypoglycemic agents, to insulin in type 2, there will be worsening of retinopathy. And especially in type 2 diabetes, when this switch is done, nearly all of them will show some progression of retinopathy, and even there can be progression of diabetic macular edema. However, in the long run, it reduces the progression of retinopathy. And there are two terms which are very commonly used whenever we speak about DME and or diabetic retinopathy and glycemic control, metabolic memory and legacy effect. So these were basically the follow-up study. In type 1, it was DCCT study, which were followed up later. And they found that the group who had an intensive treatment in the DCCT trial, after that the trial was stopped, but still they had a protection. So even in the later part, there was a protection for diabetic retinopathy. The same thing was seen in the UK-PDS population. The group which had intensive control showed some amount of protection even later on after 10 years. So this UK-PDS called it as a legacy effect, and the DCCT called it as a metabolic memory. This is something which is seen with glycemic control. This highlights early well-controlled diabetes is something which will give a protection for diabetic retinopathy for a longer time. One must also remember one of the drug, tholazine-dione, that is glutazones, they also cause macular edema. So people who have on glutazones, especially if they are also on insulin, these are the people who develop macular edema, and these are the cases you need not treat with anti-VEGF, just stop the drug, the macular edema will go off. Now, what I spoke initially was more about the success rate or how the glycemic control can influence your treatment. Coming to the safety part, the UK guidelines, they suggest that HbA1c less than 8.5 should be there before you give intravitreal injections. In India, we don't follow HbA1c, but it is the random blood sugar less than 200. Definitely, there is an advantage of using HbA1c. However, we know the cost. And the second biggest problem is if HbA1c is more, we need to probably wait for 3-4 months. That again is a little problem, and giving an intravitreal injection with a higher HbA1c, medico-legally how it will stand is a big question. So just a suggestion, the SAARC guidelines, probably we should consider HbA1c as an important parameter for managing diabetic macular edema, but for safety, we can still go ahead using the random blood sugar. Coming to the next systemic factor, that is hypertension. Many times it's very difficult to differentiate if a person has, because hypertensive retinopathy also presents with quite similar features as non-proliferative diabetic retinopathy. However, if we see more of cluster of microaneurysms in the macular area, we have intraretinal hemorrhages or a venular dilatation, they are more towards diabetes. And if you have more arteriolar changes, more cotton wool spots or intraretinal hemorrhages which are flame shaped, you more think towards hypertensive. But there is always this mixture of a mixed retinopathy where you have both diabetic and hypertensive changes. Is morphology different in hypertensive as far as DME is concerned? Yes, to some extent, the hypertension is inversely associated to macular thickness in the macular subfields. And it's also inversely related to choroidal thickness. Higher blood pressure people have a thinner choroid. And in our cohort, we have shown that it is an independent risk factor for neurosensory detachment. So on OCT, if you see NSD, always look at the blood pressure. Has BP control any influence on DME treatment? There are reports which have shown that it is the pulse pressure, which is, so you may have spontaneous variations in the macular thickness in DME, especially if there is a wide pulse pressure. So always look into the BP whenever you are, because many times we treat based on the central subfield thickness. And definitely blood pressure control has got a beneficial effect in reducing the incidence of diabetic retinopathy and progression of retinopathy. However, BP control has no metabolic memory, as we have seen with glycemic control. Regarding the response of treatment, there are no definitive studies, but MEAD study, which was with Ozurdex, it did show that when there was no hypertension, they had better visual acuity gains. And if they had more number of antihypertensive medications, meaning that the BP was more strictly controlled, they had better reduction in the central retinal thickness. So coming again to the safety part of blood pressure, what is the safe level of BP to give an intravitreal injection? One must understand this term of hypertensive urgency, where there is a severely elevated BP more than 180, 110 to 180, 120 without any sign of end organ damage. And it's important to recognize this because the mortality, it has a 2% risk of mortality in next 4 years. The surprising fact, which is there in the literature, that 20 to 30% of the people experience hypertensive urgency during injection. And the risk factors they found were the discomfort of the last injection and high systolic blood pressure. So I think it's important to maintain this BP or less than this BP when you are trying to treat with the intravitreal injection. So again, looking at guideline part, probably a systolic of less than 180, diastolic 110 should be good. Again, it's questionable whether you should monitor the blood pressure, but if possible, definitely it would be a good idea during injection. The next systemic problem are the renal problems. Many of them, they have coexistent nephropathy. And the first question comes that whether the macular edema is different. And many of us, I would know, I'm sure you will all agree that many times these patients with nephropathy come with a ischemic maculopathy. They have massive exudation. They have more peripapillary cotton wool spots, which gives us a clue that they probably have a coexisting nephropathy. On OCT, usually they also present with a neurosensory detachment, either a plain neurosensory detachment, or sometimes you'll have a diffuse edema with a neurosensory detachment. Is it safe to use intravitreal anti-VEGF? Yes, it is safe, but these are the recent nephrology guidelines, which suggest that during a follow-up of a patient who is on an intravitreal injection, if there is an increase in the blood urea nitrogen and creatinine more than 25%, probably you should switch the anti-VEGF, because it is now, there is concerns about the nephrotoxicity of anti-VEGFs, especially in diabetics. How reliable are the OCT thickness? We know they have more of edema. So one thing is in the stages, the chronic renal disease stage 1, 2, and 3 of the chronic kidney disease, the OCT parameters are pretty similar to any diabetic macular edema. However, later stages, you have more thinning, especially the inner retinal thinning is seen, especially in patients of CKD. Because normal diurnal variation is about 11%, in these patients, the diurnal variation is much more. So probably you should not just look into the OCT thickness while treating diabetic patients. Dialysis has also got an effect. Hemodialysis predominantly moves the fluid blood flow from the choroidal to the inner retinal layers. And again, it's very conflicting reports as far as literature is concerned. But uniformly, what they have found that after the first dialysis, definitely the thickness reduces. And in a case of a nephropathy, you are giving anti-VEGFs, it's good to plan the dialysis after intravitreal anti-VEGF, so that you can wash away any systemic absorbed drug too.
Sir, extremely apologies.
Yeah, just 3-4 slides more.
Okay, thank you.
So as far as effect of transplant, we had a large series from Shankar Nethralaya where we showed a 12-year follow-up that it stabilizes diabetic retinopathy. Again, if there is combined renal pancreas transplantation, there will be a quick hypoglycemic episodes, and they may have worsening of retinopathy, as I had mentioned. Which marker to look for renal parameters? So this is again a huge series with MV diabetes we had analyzed. And what we found that for PDR, eGFR is an important factor. And for my diabetic macular edema, it is urine albumin and creatinine ratio. I'll not go in much details, but because time is short, but yes, those who have DME itself is one of the factor which predisposes people have more than 2 times more risk of heart disease. But however, if a person has a recent stroke, how recent? 3 months is the thing. And if he had prior episode also, he should inform to the physician. Anemia itself is one of the risk factor for diabetic macular edema, and erythropoietin is a double-edged thing. It can improve diabetic macular edema, but it can worsen proliferative retinopathy. And this is something which many of the patients with CKD, because of renal associated anemia, they are on. So this is something one must look for. I'll not go in this. Yes, as far as lipids are important. There are OCT parameters. Just last 2 slides. I'll just quickly go. Infections, don't inject. Keto diet, bariatric procedures, there is a quick reduction. Again, there is worsening of DME. Sleep apnea is an independent risk factor for DME. And especially refractory DME, don't hesitate getting a sleep study done. Many times they have severe OSA. That may be the contributory factor. So just to conclude, it's not only an ophthalmologist, but probably a diabetologist, nephrologist, all working together, taking care of glycemic control, hypertension, lipids, nephropathy, anemia. These all are very crucial as far as a successful management of DME is concerned. Thank you very much. Any questions? I'll be happy to.
Sorry, sir, we can't take any questions as we are running late.
Sure.
2 more speakers.
No, Dr. Doshi, that leave it to us whether to discuss or not. We will finish in time. Don't worry about this.
So this is what is told to me.
So in any case, we are going to next speaker, that is Dr. Raja Narayan, who will tell us about the intravitreal VEGF therapy. Dr. Rajiv Raman, has thrown a lot of light. In fact, his first slide was the most useful slide for me, where he had those colored boxes and all those parameters are important. Thank you, Rajiv. We'll move on to Raja for telling us. Raja, we know, is a senior consultant at LV Prasad and has a lot of work in intravitreal injections. Yes, Raja.
Yeah, thank you, sir, for the kind invitation. I thank all the members present here. I'll be talking.
Can you be louder because your voice is quite feeble?
Oh, really? Okay. Yeah. So I hope you can hear me now. I'll be talking about intravitreal drug therapy. There is a lot to discuss, but I will discuss the main points, and then later on we can take up the guidelines by email with all the esteemed members in this panel. The key studies which I will cover, just to highlight the top lines, are protocol T, which compared the different anti-VEGF agents, MEAD study for DEX implant, and also protocol V when the vision is good, but there is center involving DME. The protocol I looked at.
Increase the voice, please.
Sorry, you are not able to hear me still? Okay, so protocol I looked at ranibizumab with deferred laser or prompt laser, and overall what it showed that at the end of 1 year or even at 5 years, there was about 10 letters gain in vision, or that is 2 lines of gain in vision. But what it showed was that patients who have less than 20/50 vision, that is about 6 to 618 vision at baseline, who had less than 612 or 618 vision had a much better vision. Let me just switch off my video. I think my internet is slow. So overall the vision was improved by about 15 letters if the patients had worse than 20/50 vision. So that was a main thing which we have to understand. Worse the vision at baseline, more is the improvement. Protocol T looked at bevacizumab, ranibizumab, and aflibercept comparison. what it showed was overall in the patients who were less than 20/50 vision, as I showed in the previous slide, patients had good improvement, and the maximum improvement was with Eylea or aflibercept, almost 20 letters, that is 4 lines gain in vision. So patients who have baseline vision is bad, they improve more. That's a theme which you will find all throughout different studies. Better vision at baseline, less will be the improvement. More the worse is the vision at baseline, more will be the improvement. So this slide again shows patients who have better than 612 vision, they have about 7 to 10 letters gain in vision, irrespective of whether you give Avastin, Lucentis, or Eylea. So that's the thing which we should all keep in mind. But that patients who have less good vision at baseline, even Avastin may be a good choice. And what this slide shows is that aflibercept has the greatest reduction in thickness, and bevacizumab or Avastin had the least reduction in thickness. What about this number of injections? How often do we follow up? That's the more critical question. Why we all understand and tell patients vision may not improve completely. How often should we call them? How often should we inject them? When should we re-inject? So in protocol T, they call the patients every 4 weeks. They differentiate 4 weeks and 1 month. They are very specific about 4 weeks. And then in the second year, the patients are called every 4 to 16 weeks, depending on the condition of the patient. But at 6 months or later, the patients were also advised focal or grid laser if the DME persisted. What were the retreatment criteria? They are very strict for the first 6 months. You keep on injecting unless there is success. Success means either 6/6 vision or 20/20, or there is no edema. But till then, in the first 6 months, keep on injecting. Beyond the first 6 months, they understood that patients may not always get 6/6 or flat retina. So they said that if there is worsening by 5 letters, then you re-inject. But if there is no worsening in the last 2 visits, vision is stable, you may not inject. Or if the OCT worsens by 10% or more, you again re-inject, but the OCT is stable. Even if there is edema, the vision is stable, OCT is stable, you may not re-inject. But beyond 1 year, they had a failure criteria. They said, okay, I will not inject or I will switch to steroids. That is only after 1 year. But that's something which our patients can still afford. So what happened in protocol T? 15 injections in 2 years. We all know this is not realistic probably. So we have this another option, dexamethasone implant. We also have IVTA protocol. I did look at IVTA. There were glaucoma issues, cataract issues. So if patients don't have glaucoma or they're pseudophakic, you may still consider IVTA in some of these patients. But what MEAD study showed was that patients, if you can see these top graphs, the patients who were pseudophakic did very well. But phakic patients started reducing, had less vision even after the injections. So with this, the number of injections of DEX implant was only about 4 injections in 3 years, which was not bad compared to when we see protocol T, 15 injections. So when would you switch in real world, less than 5 letter gain, less than 10% reduction in thickness? These two are called functional failure or anatomical failure. And what does the VRSI survey show? For a non-responsive DME, most of the members switched by the 3rd injection. We would never wait for 6 injections to switch. So by 3 injections, if you don't find improvement, we will switch to steroids most often and not to switch to some other agent. This is a graph showing whether they will change to another anti-VEGF. Most of us would switch to steroid instead of another anti-VEGF. And steroid at baseline at first visit was only considered if the patient had any heart attack or stroke and the patient was pseudophakic. Otherwise, patient members would still inject anti-VEGF. What about patients with good vision at baseline, but with center involving DME? Protocol we showed that whether you give injection or you do laser or you observe, there was no difference in the overall outcomes. But it's an individual physician discretion. If the patient complains of metamorphopsia, you may still go ahead and inject these patients. What about the Indian guidelines published in IJO? Anti-VEGF is recommended the first line of treatment, laser for non-central DME. And if there is central DME with good vision, we still recommend laser. Surgery for VMT ERM is recommended. And end point is that if there is no change in vision or less than 50 microns in 2 consecutive visits, then you may consider just observing these patients. One last point I would like to show here, because these are guidelines which we have to work on. We want to make sure that people who inject actually are trained in injections. This is a cataract surgeon who is giving intravitreal Ozurdex injection. Unfortunately, the cataract surgeon has not been trained in giving intravitreal injections. This injection goes and hits the lens, and the injection also is done inside the lens. And ultimately, during cataract surgery, this comes into the AC, and the Ozurdex injection also gets emulsified during surgery. So a key point which SAO must consider when recommending guidelines is that we should tell that every ophthalmologist should get trained if they want to treat DME. So in conclusion, DME generally start with anti-VEGF, switch in 2 to 3 injections. Steroids can be used for maintenance. Surgery, although can be considered, you still start off with injections. Even if there is VMT, ARM, and DME, you may still get an improvement. And edema is the most important simple determinant for decision making. We are not going into OCT biomarkers at this time. But thank you very much for your kind attention. That was my last slide. Thank you very much.
Thank you, Raja, for a lovely presentation. Very brief and to the point. Only one question: if the patient is doing well, can you give steroids for maintenance, just to increase the duration?
Yeah, in the sense if the patient is doing well, yeah, you can give definitely steroids, preferably Dex implant, because IVTA has serious issues of glaucoma, even if we are giving the preservative-free one.
So before we take up any other issues, I think we know time is up. Dr. Tariq Razali, because surgical aspects are also important with OCT telling us about VMT and ERMs and fractional kind of edema. So I'll request Tariq to share his screen. After that, we can have a small discussion and then think about guidelines issues.
Good afternoon, sir. Probably I'm here. You can hear me, sir.
Right. Please,
okay. Good afternoon, respected chairpersons, co-chairpersons, moderator, the honorable panelists, and all are here who will be taking care of all the patients of SAARC countries. I'm Tariq Reza Ali, and I got so much support from Dr. Raja Narayan to prepare this presentation. He is my consultant during my fellowship at LV Prasada Institute. So as we all know that this surgical aspect of the management of diabetic macular edema, before presentation, I want to tell that diabetes is a cause, that is diabetic patients have much more different vitreous than the non-diabetic patients. And these vitreoretinal interface abnormalities are present there for diabetic macular edema. The firm adherence of disc and macula to the posterior hyaloid, and during stretching or during PVD induction, there may be blood retinal barrier breakdown, inner blood retinal barrier breakdown, and this can cause one scaffold for cellular proliferation. This internal limiting membrane of diabetic vitreous is much more adherent to the central cellular elements. This internal limiting membrane is thicker, and more heparin sulfate proteoglycans are present. And also the biopsied ERM showed that there is much more fibromuscular cells present in the ERM, which can cause traction on the vessels of the macula. So increased cross-linking and protein glycation causes tangential macular traction, and adherent vitreous, which is adherent to the macular blood vessels, can locate the mediators of vascular permeability, which can impede the oxygenation of retina for upregulation of vascular endothelial growth factor and thereby vascular permeability. How does vitrectomy works? it is at least theoretically that vitrectomy increases the intravitreal and inner retinal oxygen level. It downregulates the VEGF synthesis, and it opens compartments of loculated cytokines, and it relieves traction exerted on macula. Vitrectomized eyes with DME have a lower prevalence of PVD than eyes with DME. And after the advent of OCT, it is clearly shown that vitreomacular adhesion is a risk factor for development of diabetic macular edema. If this patient comes to us, probably we have no doubt that we have to go for pars-plana vitrectomy. But this patient, we can try with injection anti-VEGF. But if this patient, if there is a doubt whether we will go for injection or we will directly go for pars-plana vitrectomy. Let us see one patient. This patient had only cataract, vision was 20/60, and other eye was pseudophakic. After the cataract surgery was done, the first POD vision was 20/20, but after 6 months, the patient came with very less vision, 20/80, and we decided for injection Avastin 3 doses. After Avastin, vision did not improve after 2 months after injection. So we decided for intravitreal steroid. And after steroid, after 1 month, vision was a bit improved to 20/40, but again, after 6 months, the vision again decreased to 20/200. So we decided to go for surgery, pars-plana vitrectomy, ILM peeling, and fluid gas exchange. And this surgery is very simple surgery. You all retina specialists can do this type of surgeries after vitrectomy. Then ILM peeling and fluid gas exchange was done. And this patient, after 1 month after pars-plana vitrectomy, the vision improved to 20/80, and after 1 year, the vision came to 20/30. This may be a success story for a pars-plana vitrectomy, but let us see another case. This is a 51-year male, diabetic for last 10 years on oral hypoglycemic agent, not properly controlled diabetic. He's also hypertensive and hyperlipidemia. The vision was 20/80 in right eye, 20/20 in left eye. And after, this is the FFA, shows hyperfluorescence. This is the early and this is the late. And the OCT also showed that cystoid macular edema in right eye. So we planned for injection anti-VEGF in right eye and to observe in left eye. 2 months after injection, the vision did not improve much, 20/60, and left eye maintained 20/20. And after that, the patient lost for follow-up for at least 1 year. After 1 year, when he came back, vision was 20/60 in right eye, but left eye vision was 20/40, and there was huge cystoid macular edema in both the eyes. So we decided for injection anti-VEGF. We planned for coagulation, but the patient developed vitreous hemorrhage. So you have to go for pars-plana vitrectomy and ILM peeling, and everything was done. But the vision did not improve to this patient after 6 months of surgery. This is not a very successful story after pars-plana vitrectomy. This is the surgery of Dr. Rajanarayan, and he did, that is OCT guided ERM peeling and membrane peeling. This is not available with my setup, but this will be helpful for other surgeons to do this OCT guided pars-plana vitrectomy. Another surgery by Dr. Raja, he did it with that is bimanual vitrectomy. And that is another with chandelier light. He did this bimanual vitrectomy. It was done, and we can also do this type of surgeries if needed. Here it was a very thick ERM, so it needed for bimanual surgery. Very thick ERM, it was cut, and the surgery was done. So vitrectomy in diabetic macular edema, the real world scenario is, it was first reported in literature in 1992. After that, series of cases and trials, but there is no RCT till now. So eyes with taut posterior highlight or failed previous laser, they went for pars-plana vitrectomy. Attached but non-thickened posterior highlight, those cases are also done pars-plana vitrectomy, and also persistent DME despite laser or intravitreal injection. And vitrectomy relative frequency was refractory DME with PVD, refractory DME with taut posterior highlight, refractory DME with ERM. does it really work? Another 1 minute, please. Controversy exists. Vitrectomy reduces macular thickening, but does not improve the visual acuity. The improved visual acuity with decreased macular thickening for a few months. Somebody reported that improved visual acuity with macular traction, but no improvement without traction. So this review article tells that though there is an improvement of 2-letter visual acuity difference during favoring vitrectomy, but after 12 months, this central retinal thickness actually it reversed. So most frequent complications are also retinal break and intraocular pressure rise, and also cataract developed by 68% patients in phakic patients. So in conclusion, vitrectomy produces structural and functional improvement, but probably there is no gain significantly in vision or than laser or intravitreal injection. So probably vitrectomy is not advisable, at least in SAARC countries, as primary therapy of diabetic macular edema. Thank you, ladies and gentlemen, for your patience hearing.
हाँ जी
Sure.
और जी क्या हाल है सर?
Yeah, thank you so much, Tariq. Actually, Dr. Lalit just now called saying that his connection he has lost. So, Dr. Ali, how much time do we have for discussion, or is it
I
time
don't
to
think
conclude
we have
actually?
time now. I don't think.
Okay, so oh really? Okay, so thank you all very much. I think Dr. Ali, you can take up and say, you know, when we can come up with the guidelines on all the aspects. All the talks were so important today. All of them have to be combined and then edited for joint SAARC guidelines. So maybe you can coordinate that over email with all
one
the
question,
panelists.
please. Hello.
I think I'll come up with the draft first, combining all the presentations, specifically with the systemic part and the investigation, everything. I'll distribute to all who are there today before making a final draft, and that will take probably a few weeks. I don't know how much would be the about 2 weeks or something like that, or would that be too long?
No, Dr. Eli, I think the first draft which we have prepared together, we will add few more stuff in that and then circulate to all the people. And once that is done, probably that should be, because that covers majority of the things. Only few parts we may need to add there.
Yeah, maybe let's say in 2 weeks time we can get a draft.
There is a first draft which is already prepared for the guidelines, which Dr. Eli and me have been working together for last few months, and probably we'll take it from there. We can modify that.
Yeah.
So I mean, Dr. Rajiv and Ali, we are getting this draft by 2 weeks.
Yeah.
Okay.
Yeah.
Fine. I think 2 weeks time is okay. I think it is time,
Yeah.
Then we can give some inputs, and then you can put more on it. Thank you.
Can I ask one question, please?
Okay, thank you very much. I think we have run out of time, I think.
Thank you. Thank you, Dr. Raja. Bye, Dr. Rajiv Raman.
Bye.
Everybody else, goodbye. Dr.
Bye.
Eli.
Goodbye to everybody.
Bye.
Thank you, Ava ma'am. Thank you, Azad sir. Thank you, Lalit sir, everyone. Okay, Malla sir. Thank you, everyone.
Thank you very much for patience here. Thank you.
Thank you and goodbye.
Goodbye.